Everybody. So welcome everyone to our third Math Standards Learning System webinar. This is the third one that we've done now for our colleagues within the MIST team in Scottish Government, and it's great to be at this stage because we're kind of getting the chance to have a little bit more discussion around involvement and the contribution that people make who use services and those that love them in the delivery of treatment and recovery. So I'm really excited to hear from some of the speakers today. So thank you very much for taking the time to attend our session today. There's a couple of things just to kind of keep everybody in the loop. We are using a hashtag. You'll see in that first slide there, hashtag #HisMat, if you want to go online and sort of share any reflections or any thoughts or profile any of the kind of comments that's made by speakers this morning. We do ask that you close off your video and your microphone with the exception of the speakers, only because it helps with bandwidth and things like that, and it kind of reduces any technical difficulties that we might have centrally. Usually the sort of course of the morning is kind of what you would expect around a webinar. So I'm just going to show you the agenda and take you through a little bit of that. So for those of you that I don't know, my name's Ruth Robin. I'm the lead for the improvement work that we do within Healthcare Improvement Scotland around drugs, alcohol and housing and homelessness. Some of you I've probably met. For those of you that I don't know, welcome. This is the third of our webinar series and we're going to continue to deliver them over the year ahead. So if you've got any interest in reflections or anything you'd like to share with us that you think colleagues might be interested in learning about, please do get in touch with me because we'd love to kind of continue to make sure that this is a forum for you guys to sort of share, practice and reflect and learn as much as anything else. So just get into the session today, if we can do that quite quickly. So today, as we say, this is about the involvement of those with lived experience, those who have used services, those who are using services, the people that love them and the system that's there to support them. So we are really going to focus on the importance of involvement and getting that contribution as a key kind of golden thread throughout the work that we do in relation to treatment of drug and alcohol. So please bear with us. That can be quite an emotive subject area, so please keep yourself safe in that. There's a lot of experience possibly around personal exposure to drug and alcohol or services or addiction, and that can come with a lot of emotion. So if you feel at any point that you want to leave, please look after yourself and do so. We would let you know that the chat function is a public function, and we would ask that you don't share anything private or confidential in that in order for us to just protect everybody. If for any reason you've got any cause for concern about what others are saying or sharing, you can get in touch with me direct or in the email that I've provided for you already. Please continue to mute your microphone and turn off your video. It does help with us internally in terms of bandwidth and the volume of people that we've got in accessing the link, so it does actually help that. We are using the chat function, so throughout your speakers, please use that. That is your space to kind of be heard and contribute to the discussion. We'll pick out a few comments that are made for each speaker and probably pose that back to them, time permitting. We always build in time for questions and things like that, but we tend to find they overrun. But if that does happen, we'll bring together all of the questions that we see in the chat and we'll give that to you afterwards as a sort of reflection of the session. If you've got any specific things that you want to pick up with individuals offline, we can certainly arrange that for you if you want to reach out to us after the session. So I'm just going to give you a little bit of a brief context in terms of our programme update. So for those of you that aren't aware, Healthcare Improvement Scotland were commissioned to supporting the MIST team, who I'm sure we're all familiar with now, and creating a space and a learning environment for you guys to sort of share, reflect, engage with each other and inspire each other about the challenge of implementing MAT standards, which we know is complex and we know that it's quite challenging. And I think what's safe to say is there's been so much progress in this space for the last 2 years. And I think this is an opportunity for us to hear all about that and inspire each other, because we're all in this together, and there's an opportunity for us to hear about emergent practice, to look forward and think about what might be coming down the track, and also to think about how we can use quality improvement methodologies and other things to support you in your job and delivering care at the front line. So across the course of the last sort of 6 months of the year, the team that support the MIST team are very much in the design phase at the minute. You know, we've been out and around and about meeting colleagues, doing case studies, which you should have seen online, doing our best to reflect the progress and the work that's been made in terms of embedding those MAT standards 1 to 10. And I know there's been the publication of the benchmarking report and all of that, so we've been in the background doing our best to try and reflect the current state and what's been happening and some of the progress that's made. So a couple of things that we'll be focused on in the summer months. One is an understanding of how community pharmacy can actually support the implementation of MAT standards and what are the key barriers. And we're hearing quite a lot about that in terms of same-day access and all of the challenges around the different environments that people might be in at the point that they're requesting access to medicine. So there's a lot going on. So over the coming months, you'll probably hear quite a lot from us in terms of our engagement with the pharmacy system to understand some of the challenges around prescribing and things like that. So we'll probably feed that back to you as we go and give you a little bit more insight in terms of what we're learning around that. In addition to that, we're still in this process of sort of designing what good use of our engagement is around the providers. So you'll probably hear us talking about how we might reach out to people with lived and living experience in an ongoing way, and also how we might contact and speak to providers of care across treatment and recovery. So bear with us and we'll continue to share all of that progress through these learning systems as much as anything else. So just want to give you a little bit of background in terms of what we're hoping to cover today. So we've got Suzanne Gallagher from Scottish Families Affected by Alcohol and Drugs at SFAD, and she'll give you a little bit more inside track around the importance of involvement and the critical component of families. And I think that's something that we've heard quite a lot around treatment and recovery, is the importance of having family members who can contribute to your care, who can be informed of what's happening around your care, and also can be there to help you with your recovery long term. So I think Suzanne will cover a bit of that and just give us a little bit more insight into some of the work that they've been doing. We're hoping that you'll use the chat and propose any questions or ask for any points of clarity or make comments, and we'll use that as an opportunity to share back with Suzanne exactly what you have said, and some of the, hopefully she can pick up some of the points that you're making. We're hoping to take a wee 10-minute break and let you all get a comfort break, and then come back to have a little bit more about experiential data. So Tracey Clusker, who I'm sure you'll all know from MIST at Public Health Scotland, she's going to take us a little bit through a little bit of that and give us a little bit of the inside track around what that data looks like and what it tells us. Then we're going to break into some breakout rooms, and that should automatically happen if the technology works. And you'll go into a breakout session. There'll be a facilitator who will let you know who they are, and they'll give you a little bit more detail about what you're going to cover within that facilitated session. And I think there's a couple of things we're trying to get out of that, and we'll collate all of the feedback and then use it as we progress into our next learning sessions. Afterwards, we're going to bring you back and get the facilitators to come back with key reflections of the discussion that you've had in your breakout. And that's a chance for anybody to kind of pick up any points they think hasn't been picked up or thought about, or maybe one area has something to say that they think others might be interested in. And then we're hoping to close no later than about 12:30. And it's a beautiful day in Ayrshire, so hopefully it is the same where you are and you can get finished at 12:30 one time. Okay, with that being said, I'm going to hopefully seamlessly pass over to Suzanne Gallagher at Scottish Families Affected by Alcohol and Drugs. So Suzanne, I'll pass over to you, and I'll come in with just a minute to go, just to give you a wee kind of keep you on time, and also just let you progress with the rest of your afternoon. Thank you very much, Suzanne, over to you.
Morning folks, apologies, I'm always, MD knows me knows I'm always on the move, so I'm presenting from my car and it's in sunny Crieff today, so we're beautiful. I will be dipping out straight after this because I'm going to support a family member that we've got whose son has died and we need to go to her funeral. So if you could start my slides, that would be great, thanks. So Suzanne Gallagher is my email address. It'll also be shown at the end just in case anybody needs to get in touch with me, because I'm not going to be here for the rest of the presentation, but feel free to get in touch with me, tweet me, message me, let me know how things are going. Next slide, please. So when we're looking at the MAT standards and family inclusive practice has been in policy for nearly 10 years now. So Rights, Respects and Recovery says that Scotland should be a country where we live long, healthy and active lives, regardless of where we come from, and that communities have got the right to live a long, healthy life, and they've got the free from drugs and alcohol. They've got the right to treatment with dignity and respect, and families and individuals are fully supported to reach their own recovery. So when we're looking at a framework for families affected by substance use, it needs to be a holistic approach. So we start back in August 2014 when we had equality principles, which states that services should be family inclusive as part of their practice. But then moving into October 2014, which was the outcomes framework for problem drug use, saying there's highly processed and reviewed levelled evidence that involving families and recovery care plans for affected individuals, providing family support for family members themselves is beneficial in improving outcomes for both parties. 2018, obviously Rights, Respect and Recovery, saying that we need to ensure family members will have access to support in their own right, so not as a condition of their loved one accessing care and treatment, but in their own right, and that they'll be included in their loved one's care and treatment plan and support. We're obviously May 2021, the MAT standards are saying that services will ensure people are aware of their right to have someone, such as a family member or a friend or any other person, to be included as part of their care and treatment plan, and that staff will actively assist and support people who choose that. We're then into December 2021 when we've got a framework for holistic whole family approaches, which we obviously contributed to with Scottish Government, and it's saying that workforce, a trauma-informed, compassionate, skilled, valued workforce who are family inclusive and able to increase feelings of safety trust with families. We're then into July 2022 when we've got the Change in Lives report from the Drug Death Task Force that says support and training on family inclusive practice approach should be provided for all people working in services, and this will help ensure that engagement in an individual's family and their treatment is effectively managed and supported. So again, it's that proactive inclusion of families. July 2022, we wrote a companion guide to the Drug Death Task Force recommendations, and it was about families. And families are asking for a presumption of family involvement in their loved one's care and treatment plan to be part of that family inclusive practice. So it should be an opt-out rather than an opt-in. And then we go to August 2022 when we've got the National Drugs Mission, which basically says family members are empowered to support their loved one's recovery and families are supported to achieve their own recovery. So nearly 10 years where we've got policies and reports that states that families need to be included in their loved one's care and treatment plan, but on the ground that still doesn't work. Can you move to my next slide, please? So when we say like families are welcome, services will say, families are welcome. Well, it's a kind of welcome-ish, because sometimes what families are telling us, that is not actually the case. So families tell us daily, either through the individuals that we support through our National Family Support Service, regional family support services, and more so through our national helpline, that they continue to be routinely excluded and dismissed by care and treatment services, and that families are rarely offered support in their own right. So when you phone a service, it's never about them, it's always about the person who uses substances, and nobody ever puts them at the centre of the focus. So our family reference group made recommendations in June 2022 that families must be included as partners in care through the presumption of family involvement. So services should be proactively trying to work with that person engaging with their services to get them to involve some other person in their care and treatment plan. There should be mandatory family inclusive practice training so that individuals who are working in services, what is family inclusive practice? How can I put that into practice? What is it? It's not just about a mum going to an appointment with her son's addictions worker. That's not just family inclusive practice. You can bring in other elements to have family inclusive practice if the person you're engaging with in your service doesn't consent for their loved one to be part of their care and treatment plan. You can still include families in that care and treatment plan. And we would like there to be a specific MAT standard for families so that they are continually recognised and it can be reported on and it can be benchmarked again. But families also need to be given support in their own right, regardless of where their loved one is on their access to treatment or their recovery plan. Next slide, please. So when we look at whether families are welcome, these are what we call family support triangles, family inclusive practice triangles. So the one on the left is tokenistic family inclusion, and you'll have professionals that say that mum, she's always phoning here, she's always moaning, she's a busybody, she's meddling. If somebody is continually phoning your service, it's coming from a place of frustration, a place of anxiety and fear that their loved one is going to die. If somebody's continually having to contact your service, you need to look at how can you support that individual in a different way. You need to put the focus on that individual and not on their loved one. You've then got professionals who go, oh, it's all right, I'll sort this because I know better. You've completely invalidated how that family member feels. They're the one that's living this 24/7 with their family member. They know their family really, really well, and you're saying, I know better than you, completely invalidating where they actually are. And families sometimes feel completely powerless with regards to, feeling blamed for things that are out with their control. On the right, we've got what we would call a meaningful family inclusion triangle. So We're looking at vulnerable families and saying, you know, we'd love to use your knowledge. You've got such great skills and experience of how we can do things differently. Please get involved with us. You then get a set of professionals that go, you know, how can I use my skills and experience combined with your skills and experience that we can really make effective change? And then you've got a caring professional who, if a mother's contacting a service, that they're just like, I'm going to completely listen to you and I'm going to take on board absolutely everything you're saying, rather than saying, if your son's not prepared to engage with the service, there's nothing I can do. Can you move on to the next slide, please? So for MAT standards and families, you know, the first one is that some families are going to make sure that the person that they're engaging to knows that they've got a right to have somebody part of their care and treatment plan, and that should be actively encouraged. You know, if somebody's saying they don't want somebody part of their care and treatment plan, we should be delving into that to say why. Why is it you don't want somebody part of your care and treatment plan? But families really should be welcome at appointments and be treated with dignity and respect, and really be acknowledged that their skills and experience in this situation is valuable to allow you to be able to support their loved one in a more effective manner. And families need to feel that they can be really involved in their loved one's care and treatment plan, because, you know, families can be really influential to support change in somebody who has got problematic substance use if they're supported in the correct manner. We know that evidence-based interventions can influence somebody to change and engage with services, and we need to harness the power of families to make sure that that comes into play. But families need to be confident that if they contact a service with a concern about their loved one, themselves, or another individual, that service is going to take that on board, and that they're going to put some kind of timely support and action in place to minimise that potential harm to the individual or any other family members and anybody around about them. But there also needs to be pathways that families know that if they're accessing treatment with their loved one, so they're part of their care and treatment plan, but they feel that they're not getting all the information, that they can be able to advocate on their loved one's behalf, and that they get access to advocacy services. We've got a mum that we have supported before whose son was like, I want my mum to be part of my care and treatment plan, but the service felt that she was quite, you know, disruptive in appointments, so she was then excluded, even though the individual wanted her to be part of that care and treatment plan. They need to have advocacy services to make sure that their rights are being upheld. And that families, if they're contacting a service, need to have a named worker. If mum's phoning on Monday with a concern and she speaks to one worker, she phones on a Wednesday with another concern and she speaks to a different worker, it's potentially no reason flags in a service that we've got a concern, an overall concern, multiple escalating concerns about an individual. So if they have a named worker, then you've got that continuity of care. And families should be really included in the design and delivery of MAT. You know, they've got a lot of experience. We talk about experiential data, and there's a lot of focus on the people who use our services, and we need to focus on the people round about them, because they do have a lot of skills and experience that they can feed into that. And that families really need to be able to provide feedback to services. They should be able to put a complaint in, whether that's about care planning, about the treatment that they feel their loved one is accessing, and that should be through formal and informal channels, and even through anonymous channels would be highly beneficial, because some families feel they don't want to raise a concern because they feel that their loved one's going to be penalised for that within the treatment service, and we need to try and minimise that. Next slide, please. So families were really hopeful when the MAT standards came in. They were just like, this is great, something bright and shiny. It's going to really make a difference here. It's going to be, you know, really meet the needs of their vulnerable loved ones, and it's a significant chance to do things differently to make sure that people are being supported. They really appreciated that there was 10 standards that were broken down into specific areas, and it wasn't just lumped into treatment as a whole, that there was going to be accountability and transparency, and that there was really an acknowledgement of them being included and supported and recognised as, in the majority, they are the primary caregivers for the person who has a problem with alcohol or drugs. And they felt that there was, because there was going to be choice of support, that it was going to be a wider access of support, and it wasn't just going to be what they've perceived to be methadone clinics, and that the rapid access to treatment and support would minimise risks of harms and prevent their loved ones dying. Next slide, please. So when we look at what is not working, so families really feel that they were hopeful that there's 10 standards were going to be implemented in these 10 areas were going to minimise the harms to their loved ones, but there seems to be a significant concentration on MAT standards 1 to 5. In the background, there is work to 6 to 10 ongoing, but it's not as widely known. When they look at the benchmarking report as to what's actually being reported on and what they're seeing on the ground, they refer to that as a significant implementation gap. And there's really a frustration around the level of support that their loved ones have. If their loved ones are not using opiates, there is a perception that the MAT standards are opiate standards. So when their loved ones experiencing issues with like alcohol, cocaine, benzos, they don't get that rapid access to treatment. So you can present to services, you know, 24, 48 hours, you can get put on treatment if it's opiates, but if it's alcohol or other drugs, it's a wait for you to access that support. And that they feel that the treatment shouldn't just be looking at it from a medical model. So if you are using other substances that don't need OST, how could the loved one, be looking to access psychosocial and mental health support at that point of contacting services? It's not offered in the same timescales as OST, if it's even offered at all. And we're not to say that statutory services are going to be the person that might deliver that psychosocial support, but can we do a referral into a third sector provider in that locality area that's going to be able to support that individual and work with them to kind of minimise the harms for them? Next slide, please. So again, families still feel that there's no recognition of them being the primary caregivers for their loved ones. So across Scotland, it is a postcode lottery as to kind of what level of support you get. In order for families to be able to consistently offer that level of support, so to consistently be that cheerleader, keeping check on that individual, checking that they're alive, checking that they've got food, everything comes from an emotional, physical and often financial cost for that individual. And that families feel that when they contact treatment services, there's no consideration of how this is impacting on them, and it's not acknowledged and it's often dismissed. So we had a referral in from the ambulance service for a lady who had tried to complete suicide. It was a mental health call for them. When they went out to speak to that individual, the reason why she tried to complete suicide is her son's drug use was so chaotic that she felt he was going to die and she can't watch him die. So she felt she needs to go first and she'll see him on the other side. She has contacted services 42 times to say, you need to help me. My son's dying. You know, I can see him, he's fading away in front of me. And it's like, well, if he doesn't want to engage in treatment, there's not a lot that we can do. So we need to manage. If we're looking at harm reduction, we need to broaden that for the harms that families and communities experience when they've got a loved one who's got problematic substance use. Next slide, please. So when we say to families what it need, families need to be recognised and involved. So if somebody phones a treatment service and their son is not prepared to engage or isn't engaging, how can you still include families in that? So taking information in from families to look at care plan, and do we have to have a set of outreach for that individual? But they really need that there needs to be a commissioned, dedicated, ring-fenced family support service in every ADP area. Services often advertise that they provide family support, and a family will maybe contact that service and go, oh, I'm really stressed because my son's drug use. Well, if he's not prepared to engage, there's nothing we can do. That's not family support. What you're offering is family inclusive practice. But even then, you're only looking at family inclusive practice as if this individual is engaging, then you can be included in that care and treatment plan, when family inclusive practice is wider than that. So all services who provide support or treatment to anybody who's got a problem with alcohol or drugs should have family inclusive practice training. Our organisation does offer family inclusive practice training. And we should be looking at that there's an automatic support. So if somebody is contacting your service about their loved one, you should be automatically looking that they're the caregiver and that they need support to help manage this situation. When we look at levels of information that families need, GDPR, a lot of services hide behind GDPR. Sorry, can I discuss that with you because he's not consented? So consent, there needs to be layers of consent. Consent can't be an all in or an all out. If you're engaging with somebody and they're accessing your service for treatment, when we're looking at how you offer family inclusive practice, if we say, do you want somebody part of your care and treatment plan? Somebody goes, no, that's okay. And it's ticked no. Then mum phones with a concern. I'm concerned about my son. Sorry, we can't discuss that with you. He hasn't consented for your involvement. Whereas if we change the phrasing around that of who in your family or friend circle do you want to be part of your care and treatment plan, it then invokes a conversation. Well, I wouldn't want such and such. Why wouldn't you want such and such? Oh, I don't want them to know that I'm potentially using drugs and, you know, illicit substances on top of my script. Well, then look at layers of consent. So your base layer of consent could be, if your identified caregivers are contacting us with a concern about your well-being, can I tell them that I've spoken to you, you're engaging and that you're okay? You know, relieve the anxieties that families are feeling that you as a service are not doing anything at all to help their loved one. And a lot of that comes from misinformation that they're being given. You know, your next layer of consent could be that somebody's going to be part of that care and treatment plan. You're going to share some level of information with them, and then we should be an all in, like absolutely nothing's off the table. Families really struggle with the fact that there's no out-of-hours provision or public holiday support for MAT standards or anybody who's in that kind of crisis stage. They're quite hopeful that there's a couple of services have now been advertising a kind of out-of-hours service, and it may be a Thursday to Sunday between set hours or a Monday to Wednesday between set hours. It's a start, but they feel that there needs to be wider access out-of-hours support, because a lot of the times when their loved one is in that crisis stage, it's the families that are left to manage that, and if they're not being appropriately supported in that, then they're really going to struggle with this. Families really feel that all substances need to be covered under MAT, regardless. We're not just talking about opiates here. We need to be considering all services, all agencies involved in your ADP area. If somebody's coming to you for support, who can provide that support? So looking at, like, have you got a person of concern group? Have you got a group where you're going, like, this individual's come in, that's not something that we would support, who is in our multi-agency approach, who could best meet that individual's need? Families are really struggling just now with the fact that there's the lack of anticipatory care. So we've got near fatal overdose pathways, and we're using that NFO data for the ambulance service, but we know a high proportion of people who experience a fatal overdose die at the first time that they have an overdose. So we're waiting for somebody to have a near fatal overdose before we're trying that assertive outreach service. So some areas are only going on ambulance data. Other areas are offering the opportunity for families. If you are concerned about somebody and you feel that they're at risk of a near fatal overdose, you can refer that individual into that service regardless of whether they're consenting. And then it's that assertive outreach, anticipatory care. Could we try and put some kind of harm reduction measures around that individual? That needs to be the case across all areas in Scotland. Families need to be recognised that they're watching their loved one 24/7, and they can see a decline as it's coming before it gets to that significant point where potentially somebody could have a near fatal overdose. A lot of families are struggling with misinformation, so their loved one might not be telling them about what's happening in the service, but so they'll phone a service to say, I've got a concern about my son. The escalation of concerns, what families would really appreciate is some kind of documentation of, if I phone a service and tell you I've got a concern about my son, what are you doing with that information? Where does it go? So a lot of services will be like, all right, okay, we'll take that in. Are they engaging with services? If they're not engaging with services, we can look at assertive outreach. Can they go and get that individual? If they're engaging with services, when did we last see them? Who's last spoken to them? Let's get them in for an appointment, a face-to-face appointment. So there is an escalation of concern when somebody brings a concern in, but are families' concerns really validated and escalated in the same manner? If you could have some kind of process of escalation of concerns. We've been looking at this about for the MAT standards in criminal justice settings, when families phone a prison to say, oh, I've got a concern about my son. What did the prison do with that data? Now they've got a process that they put in place. Publish it, make it widely known, because this level of misinformation, sorry, we can't tell you this, families really feel that you're not looking after their loved ones when there is a lot of good work getting done, but because they're not aware of what's actually getting done, it seems like things are not changing. And there needs to be an automatic discussion around support requirements for any family member or friend who contacts your service. And that could be as simple as listening to their concerns. I'm taking that on board, telling them what you're going to do with that information. So we're going to pass it over. We'll try and get them in for an appointment. We'll try and get with a assertive outreach team to have a chat with them. You know, show them that you're trying to actively engage their loved one, but then say to them, can we refer you to our partner organisation, Scottish Families, for a discussion around what your wider support needs are for your family? So if you were to say to somebody, can we refer you for family support? They'll be like, I don't need help, it's my son that needs help. When a lot of families don't recognise how help could benefit them, or, you know, them being included in family support and learning new tools and techniques and how to engage with their loved one can move them through the cycle and change and get them to engage with a treatment service. We need to be harnessing the power of families, because they love the fact that they'll love and they'll do absolutely anything for their family. We need to harness that power and use it for the absolute positive to make change for individuals and reduce harms for individuals and communities. Next slide, please. So here's my details again. In Scotland, we now have a family inclusive practice development officer. So Daryl McLeister from our organisation is looking to support organisations to, you know, deliver training. How can we come along and support with you? How can we look at your assessment process? How can you be more family inclusive so that you're actually listening to families and that you're acknowledging them, you're using their information to be able to kind of make effective change in your area? And if anybody's got any questions, I will answer them before I run away and abandon you. Open for questions.
Thank you so much, Suze. I sometimes don't know that I've met anybody that speaks faster than me. So that was great. I was keeping up with you. I've got a quick. We're actually going to put a poll up for colleagues as well to contribute and give us a bit of reflection and feedback. But there's a couple of questions that I've got, if you don't mind, before we open it up and see what questions have popped in the chat. I was really thoughtful about what you were saying around the experience of consent when there's, you know, real concerns about someone's well-being and sort of when you're in the midst of, let's say, chaos, just for the benefit of making my point. And in my experience in services, that level of chaos often changes. So there's periods where things are stable-ish, let's say, things where it's really, you're really concerned and there's big concerns about where are they, what's happening. And in homeless services, in my experience, we would often kind of connect to other professionals to kind of try and establish safety, well-being, whereabouts and things like that. Have you had experience, or can you share with us an example where that balance is working between escalating of concerns and the service picking them up helpfully and being able to get a solution? Like, have you saw something that you think, wow, now this is it, this is the right balance between consent and concern, that we're not breaching human rights in terms of the individual's choice, but we're also recognising that a family and the service have got concerns? Could you share with us if you've got an example where that balance works?
What we tend to find is if somebody's been supported through a third sector organisation, that they're open to say that we've seen that individual, you know, that they'll acknowledge, they're not going to share information, but just to let a family member know if we've caught sight of that individual and that they're okay. But statutory services very much are GDPR. We can't, because if the consent button has not been ticked, I'm not prepared to discuss that with you. But families appreciate that if consent's not been granted, that you can't discuss their care and treatment plan. But then to say to a family member, right, give me your concerns. What are your concerns? Right, I'm taking all that, I'm writing that down. Here's what I'm going to do with that information. So a family member goes, right, I've told you, you're going to pass that on and something's going to be done about that. If the individual's still not willing to engage with your service, that family member's tried everything they can do to try and escalate that concern. But see, when there's not that process in place, or there's not that acknowledge of families, when they phone up and it's like, sorry, we can't have that concern, we can't discuss that with you. So that's where family support really kind of meets that, because we can explain to families, well, this is where, well, they can't tell that information. But if they don't have somebody to go to explain that information or try and de-escalate their concerns, and their concerns may be coming from a place of frustration, and family support can de-escalate that. But if somebody's not being offered that broader support, then they're just going to spiral into a state of, you don't care and nobody's doing anything for my son. But
sorry, I was just going to add, I totally agree with you, and I think, having worked in statutory services for many years, I know how hard it is to want to be able to share what you know, but being felt that I might get myself into trouble. So I totally understand the complexity of that, and I think what I'm hoping that we'll be able to pick up a conversation with Daryl anyway. But I think what might be great is for us to think about, how do we encourage the testing of these models of care where there is a sort of named, nominated individual that can kind of knit together, you know, this kind of information source? Because oftentimes when I've been involved in any kind of after action reviews in relation to people who we've been concerned about, or there's been significant case reviews around, it's often that from a statutory perspective that's missing. There's no one person who has got ownership and responsibility for hearing the family concern, reacting to that, tracking whereabouts and, you know, safety, and oftentimes we all think everyone else is doing it. So addictions think social work's doing it, social work think addiction's doing it, we think the family are doing it, you know, and it kind of goes round. So I think it'd be really interesting to sort of start to define what does good look like in that conversation, because it's such a key issue, especially when you're concerned about someone. And I know that oftentimes in my experience making referrals to social work, if you're really concerned about that person being at risk, there's this conversation about capacity to make decisions and all of that. So I think it's a really valid point. There's a couple of questions in the chat, Suze, if you don't mind, if I'll just pick up, but I see there's a hand up, so I'm just going to invite Penny Halliday in, if you want to come in, Penny, from NHS of Tracey Gallagher.
Yeah.
Great, over to you.
I know, Suze, she'll not be surprised that I've got a question. It's more an observation than a question. what you just described reminds me so much of when I was a non-exec with Dumfries and Galloway Health Board. And you know, the fact that there was practices brought in where carers, unpaid carers who are family members, would be expected to be invited to discharge meetings when people, you know, when their loved ones were being sent home from hospital. And we found that this was haphazard. It wasn't happening, you know, as often as it should have done. Speaking to unpaid carers, they would tell me locally that no, they were never asked to a discharge meeting, and they were expected to just, you know, accept that their family member was getting home on a certain day at a certain time, and just to be able to spring into action, you know, without any involvement or consultation with the family member at all. So it reminds me of this. And I think that there's something around the whole culture of professionals respecting the expertise that families have when they're caring for somebody who is unwell. And I think that's a whole culture thing as well, whether it be, you know, families who are caring for somebody who, you know, is using drugs or alcohol, or whether it's a family member caring for somebody with dementia. It really doesn't matter. It's about treating people with respect and listening to them, and realising that, you know, what you described as the different levels of engagement, to be able to absolutely say, well, we can't tell you anything because your loved one said that, you know, we've not to discuss this with any family member, but tell me what it is that's bothering you. That would be absolutely fantastic. So I think what I'm saying is, this is a big nut to crack. And it's got to be a culture change. Like the other things, you know, like stigma, etc. I think as far as families are concerned in relation to family members who are affected by drugs and alcohol, it definitely needs to be a big culture change, and there needs to be some strategic approach. And perhaps, I think you had it in one of your slides, that there should be, part of the MAT standards should be regarding families, might be a way forward with that.
Thank you very much for that. And I think I see in the chat there's a couple of comments been picked up, Penny. I don't know if you want to have a look at them as well. What I'm thoughtful about is how we use this webinar or this learning series to maybe pick up some of these points. Because I think if we can hear about practice where they're able to get that balance right, and where we're able to see emergent practice of that family inclusive practice that you talked about, Susan, I hope I'm picking that up right. I think it would be really good to maybe showcase some of that, what that looks like and how that can integrate to other care environments as well. And I'm also thoughtful about the point that you're making, Penny, around culture. So we're connected to Scottish Government's workforce work stream around, you know, addressing some of the kind of workforce issues around treatment and recovery. So why don't I take that, I'll sort of pick that up with our colleagues there and just express to them some of the feedback that we've had today. But I'll put a question in the chat, colleagues, if you don't mind just responding to that, and we'll gather it up in terms of how could we use these series of webinars and learning events to pick up some of the points that you have made, Suze, and of course Penny. So that would be great for us in terms of just making sure that we can use this time and share some of that practice and hear about some of that family inclusive stuff, because I think the issue around consent and chaos is a really important one, and something that certainly in statutory services we battled with a lot when I was working in the front line. So I do think it's of real value for us to crack that nut, as you were saying. Okay, I'm going to give us a short break. We're 2 minutes over, which is great, because usually at this point is way more than that. Can I ask you just to regroup then at 11:50, just to keep me to time, and if you just take a wee 8-minute break. So if you leave the room, you just rejoin the link that you have, and we'll see you back here at 11:50 if you don't mind. That's great. Thank you very much, Suze, for your time as well this morning. Thanks.
No bother. Thanks, guys. Hope you have a good session. Bye-bye.
Hi, folks. Hope everybody's rejoined us. I don't seem to have a huge drop-off, which is always positive at the break. You'll see on your screen, or you should see on your screen, a poll that we've got. We've got 3 specific questions that we're keen to get the audience to contribute to. The answers to that will help us design our next future sessions. So please take a wee minute, if you don't mind, to just answer those as they present your screen. If you go along the poll, you'll see the 3 different questions. I think they are numbered, which should make it a little bit easier. And the question that I was proposing just before we finished there about how can we use this learning series to hear more about that kind of family inclusive practice, or how we encourage and get other people and other kind of groups involved in the work that we're doing within Healthcare Improvement Scotland, but critically within the MAT work. So if you please just take a wee bit of time to share your suggestions and ideas, we'll collate that. One of our knowledge specialists is on the call today, so she'll kind of pull all that together and knit it into something quite interesting, hopefully, and we can present that at the next sort of session that we've got in the diary. So without further ado, I'm going to invite Tracey Clusker across, if that's okay, Tracey.
Yeah.
So I think you know most people in the room, I would suspect, Tracey, if I haven't not already visited them face to face, certainly online. And you're going to cover with us a bit of the kind of experiential data collection, is that right?
Yes.
So I'm going to pass to you. I'll probably come back on just about a minute to go, just to kind of keep us to time, if that's all right, Tracey.
Great, thanks.
So over to you.
Thank you very much. So I'm Tracey Clusker, so I'm the clinical lead nurse consultant for the MIS team. For those that don't know, it's the MAT implementation support team. And I'm here covering actually today for Annette Gallimore, who's on leave. So hopefully I can do her presentation credit, but we do have other colleagues from our experiential team on this call, such as Becky. If there's any questions that I can't answer, certainly Becky could certainly do so. And I just want to talk around the experiential data collection. And I think when you hear the really powerful presentation from Suzanne Gallagher around that's huge experiential feedback she's got from families, but I guess the gap is, when is that used to influence service improvement? And it sounds like there's frustration there because it's not happening for these families who are, you know, and I remember speaking to Susie a year ago, and some of these issues were around them and they continue to be. So I think this really demonstrates the importance of people do give you feedback. How do we feed that into service improvement? So I'm going to talk today just about community engagement and how you use the data for service improvement. So next slide, please. So the MIS team is the MAT Standards Implementation Support Team. Our remit is to support alcohol and drug partnerships to implement the 10 MAT standards. So over the last year, 2 years, we've been working with every alcohol and drug partnership to offer support. But a huge part of the role also is to evidence that the standards are being implemented. So we have 3 evidence streams. One is process. So in terms of what a process measure is, that's looking at the governance. So for example, for MAT Standard 1, do you have a pathway that's seamless to allow people to access your service? Are they aware how to come into the service? Is that visible? Equally, families should know how they access services for their loved ones, and is there, you know, prescribing guidance that allows you to prescribe opiate substitute therapy on the same day. So a great deal of work's been done to support areas with process measures, and actually for all areas now there is evidence that these processes, so the infrastructure's there to safely implement the standards. We also collect numerical data, so we know that the infrastructure's there. The numbers tell us, you know, the things like the time it takes from somebody referring to a service to the very point that they get that prescription, for example. And we do take the feedback around the numerical data for MAT1 is very fixed on opiate substitute therapy, but this is an ongoing process. So this was a starting point. We had to measure that because there was huge inconsistencies. But going forward, we'd be looking at what's the role, you know, how do we ensure people who are using benzodiazepine stimulants, how do they access the service? What is that service? What does it look like? And I think that's where third sector will probably be able to evidence more some of the absolute essential role that they play. And lastly, what we're here to talk about today is the experiential evidence. So we, in terms of the benchmarking report, which we can send a link to, we did take these 3 evidence streams for the 29 alcohol and drug partnerships, and we assessed people. Now, what you can see from the data is processes are in place, the times for people waiting, or the number of people accessing different choice of medication. You know, there's a trajectory where you can see improvement. However, there was a real lack of really good experiential evidence. Now, that's not across the board, but there is some areas who have really struggled to gain that, or maybe perhaps not invested in it, or seen this as work that's really worthwhile. So we are really keen over the next year to give really targeted support from the experiential team, which means we have to expand our programme. Next slide, please. So the key elements of what we want to gather is we want this evidence. So some of the stuff that Susie was talking about, some of the issues families raise, you know, if we have that experiential evidence, we want it from families, we want it from people delivering services. Do they feel supported to deliver services? If they're innovative, you know, is there innovation supported? Is there leadership? And from people accessing treatment. I think some of the feedback, and Becky might want to comment even in the chat, I think accessing family members seems to be a bit of a struggle for some alcohol and drug partnerships. So we need to really work out how we engage with family members. There's 3 core questionnaires, and there's bank questions when necessary. And the evidence, as I say, is gathered by a local team. So what we've been doing over the last year is the local alcohol and drug partnerships have nominated people to undertake the training, to do the interviews, and that could be a range of people. And I think it works best if it is a range of people. So people accessing treatment, it'd be good for them to be involved, service providers and families and nominated people. Next slide, please. So what is the experiential programme? Because there seems to be a great deal of confusion. So it's an ongoing dialogue. So what we're not looking for in terms of experiential evidence is a one-off survey or research project. So there's some really good work where that's really useful, but in terms of this is ongoing dialogue with people, most probably linked to people who work in the NHS, maybe had patient experience work. That maybe is the closest link, but what we want to really do is meet with people on an ongoing basis. So it's not a case of, you know, we've now given our information, you know, we've got our benchmark and report, that's, you know, that's it. What we want to see is that ongoing dialogue around how people are accessing services, what that service is like, what's the quality like, are things improving for families? And I think for a lot of the standards, I guess from our point of view, you know, they're implemented when the people using them and their families say that they're implemented. You know, the numbers in the process doesn't give us that information at all. It's not qualitative research, although it draws on the research tools and methodology, and the questions are all open-ended so that they're not fixed. So it's not a closed questions survey. And what we really want to do is use it as an improvement cycle. So for people who are familiar with quality improvement methodology, you should be getting that feedback from people, using it in real time when you can to change and develop your services. You know, and you've heard, you know, great feedback from Susie around when that's not happened and the frustration that that can create for people or the trust in a service. Next slide, please. So the key elements are what we are hoping to do in terms of giving guidance, each ADP to have an experiential lead. So this is a huge piece of work that really requires investment. Someone to lead leadership, to coordinate, oversee the local team and process the information. So you're gathering that information, you're nominating people who can do the questions, getting access to services across the board, but you want that information to come back to be processed to service improvement. The experiential lead will recruit, train local interviews, establishment of local processes, so that's data protection, confidentiality, support. So some people are using people with lived living experience to carry out interviews, or indeed if it's a family member, what's that support and supervision to ensure there's a safety and a support for people carrying out the interviews, and a programme plan for that work to link into all the service improvement for the standards. Next slide, please. Nearly done, Ruth. So an expanded experiential programme. So as I said, we've worked with all the local teams, and this is the first year they've given evidence in a consistent way across Scotland. So the questionnaires are consistent, and we were able to get benchmark consistently across alcohol and drug partnerships. What we're doing for 2023 to 2024, we need to continue the service improvement work, but what we want to do is expand the experiential programme because it's the biggest gap in the evidence. So what we will be doing is expanding it to ensure that justice is covered, so people in prison, transitioning through police custody, any justice settings, and we will be developing a MAT Standard 11 which is a community engagement for improvement, which links most to maybe what Susie and families are looking for, and we'll be developing a service specification for the expansion of this. Next slide, please. So what is MAT Standard 11? It will underpin all the MAT standards, so it should be peppered through every standard 1 to 10. It will embed community engagement, so people are involved in service improvement work, who are using services, who are affected by how services are delivered, and it will embed the current experiential processes into practice. The criteria of this is going to be produced over the summer, so we have a small core group, which some people on this call are probably on, that I will be sharing with support from Becky. So we will meet with people to do a consultation to get the standard in a place or at a point where we can share it with people for wider consultation, and it'll be linked to the service specification that will detail how we're planning to expand the experiential programme, and that's in development also to be complete by September. Next slide, please. So I will just summarise. So, you know, the part, I suppose today what we're really looking for is to understand some of the issues that people have in terms of gaining experiential evidence. How do we support you in terms of the MIS team? And if it's becoming a standard, how will you manage, what would be your challenges in implementing a MAT 11 standard where you're using your experiential data, the infrastructure's in place, and you've got some leadership investment in it, and how do you link it to your improvement work? So I don't know if you want to lead us on to this breakout rooms, Ruth, or you want me to say the questions? So thank you for your time.
Thank you very much, Tracey. It's great to hear. I know we probably could keep adding to the MAT standards, couldn't we? So it's great to see, though, that that one has been specifically called out, because I know it's massively important for us in terms of just based on what Suze was saying earlier, but just making sure that we get that right in terms of the people who use services, the people who love them, that support them after they use services. So I really welcome that, and I think it's a fantastic serendipitous opportunity for us within the iHub to kind of support you in that work. So please reach out to us, Tracey, if we can. We're about to move around organisationally, so it'd be great to be part of that. Okay, so as Tracey was saying, we're just about to take you into some breakout rooms, and the system and the computer and technology, fingers crossed, should automatically take you out. There'll be a Miro board. So for those of you that haven't used Miro, it's a sort of whiteboard, virtual whiteboard, and there's opportunities to contribute. If you don't have the technology or the system doesn't load for you, please use the chat function of this meeting and we can always add it in. So the next steps will be that we're going to ask you to consider these kind of questions in relation to your local context. So the computer system should automatically just start to split you up into rooms. There's a number of different facilitators, and we'll put their names in the chat so that you know what room you're in. We'll then tell you who the facilitator is. So a couple of things to consider whilst we just transfer you over. What might be the challenges for you in relation to that MAT 11 that Tracey has shared, and I'm sure that detail you'll get in your breakout rooms. How will we make this work? What are the key considerations around that? What's already happening is a good practice that's already out there, which is what has been the theme of MAT, isn't it? That there's a number of really good innovation happening locally. And what are our creative solutions? So the link to the Miro is in the chat, which you should all be able to access. So I think these are all joining back into the room at once. So hopefully you can all see and hear me okay. We're going to use the last sort of 15 minutes. I'm getting some feedback. Has somebody got their microphone open? Can we just check? Thank you very much to our facilitators who facilitated those conversations, and I'm going to invite each of them in turn just to give us a couple of kind of top reflections from each of the breakout sessions that you were in, and we'll use that information to sort of help us in the future as much as anything else. So if everybody's back in the room and all the rooms are sort of now closed, I'm just going to invite you in order. So Steph Stewart, can you come in? Can I just ask facilitators just to introduce themselves to the audience for those of you who don't know everyone, and for those of you who've never met our facilitators. So Steph, I don't know if you can open up your camera and your microphone and share us some of the kind of top reflections from your breakout session.
Yeah, no problems. I'm Stephanie Stewart. I'm the Senior Improvement Advisor working for MAT Standards within HIS. And as I say, we had obviously we were the first breakout session, so to speak. So our kind of key reflections, certainly underneath question 1, which was around what maybe the challenge is, you know, one of the reflections on that was just basically getting the engagement from people, so sort of getting people to participate, just especially when it is in that kind of more formal way, and using the questionnaire that was used previously, you know, for that benchmarking report, and also kind of having that time and capability to kind of gain meaningful feedback, you know, from people basically. So that was the kind of sort of 2 things, well, the ones that we touched on around those challenges. You know, how can we make it work? We did talk about, you know, being quite opportunistic in terms of how we get that feedback. You know, is it that we do it when we're in the moment with the person? But like that, we were reflecting, obviously, that does depend on your relationship with that person and the trust that was there.
Yeah.
And then also like that, taking the opportunity sometimes to say, right, well, actually, maybe just now isn't the best time, but let's go for a coffee and do it at a later date. And again, it's about, I suppose it's really underpinned by that, having that relationship and trust within that. And then in terms of sort of like creative solutions and, you know, what's happening already, one of the participants shared in terms of they use incentive vouchers to kind of get people on board, and that's funded by the ADP. So they've got like ASDA vouchers that they give for people that are taking part in these. Yeah, feedbacks basically.
Yeah.
So hopefully I haven't missed anything. Obviously, guys, if there's anyone in the room that I have missed anything key from our breakout, please do pop in.
Thank you very much, Steph. And also the Miro board will be open, so people can continue to kind of contribute to the Miro board if that's helpful. Thanks very much, Steph. Adrian, you want to open your microphone, put your camera on and introduce yourself and let us know what your feedback was? Hi, Adrian.
Hi, I'm Adrian McKenzie, pharmacy clinical lead with working on the MAT standards with his. So from my group, just I'm going to skirt over anything that's a duplicate. We're talking about confidentiality within islands and small communities, and one of the solutions that's already been explored is about mutual support, using interviews from other boards to help get round that. There's a challenge around turnover of trained interviewers, and the need for longer term funding around posts, particularly those that are leading on the experiential part of this, the data, because it is so key, both in terms of measuring performance, but also trying to move this forward, particularly as we move to MAT 11. Some people were feeling a little daunted by this, that it's quite a challenge, and Suze did set out quite a challenge to around how services are delivered. In terms of the successes, one of her comments was how successful they felt that the Resi Rehab had been around this, and whether there's some learnings that we can take from that, which I know is a discussion that we've had internally, and we've got some links there. In fact, I'll not steal anybody's thunder who comes on to talk about that.
Thanks, Adrian. While Sophia opens our camera and things like that, I'll just pick that point up. So externally, we have our MAT team and we have our residential rehab team, but internally, we're very much one and the same in terms of the substance use support that we offer the system. So I think you're going to meet a couple of key colleagues that work within the residential rehab works team anyway, as we go across the feedback. So thank you, Sophia. So over to you.
Okay, hi everyone. As we said, I'm Sophia. I'm the knowledge specialist, and that's primarily supporting his MAT standards work. And I'll be the one reviewing all of your contributions to this board. So thank you so much for your engagement today. Lots of good stuff from this group as well. And we were talking mainly about how we can make this work, what we're already doing, how we can continue doing that, and also doing it with an innovative, creative solutions approach. So there's a lot of discussion about accessibility of promotional materials, keeping those refreshed, using posters, using social media, and also gathering feedback as well. So going out into the community to do so. There was also some discussion about how we can continue the current models working. And we're seeing, you know, the challenges about resources and funding are across a lot of the MAT implementation. But partnership working seems to be working really well towards maximising what we already do have and continue to make the most of third sector resources as well, getting that support in, working together. And I think that really kind of makes the most of everyone's expertise, making sure that everyone's contributing to the system and keeping the open communication as well as a recurring theme. And again, like I said, to my own group, please do keep contributing to the Mire board. I'll keep it open. If you're a reflector and have anything else that you can think of over the weekend that you just need to add it, please do.
That's great. Thank you so much, Sophia. That's helpful. Lawrence, are you there?
I am, Ruth. Thanks. Hi, I'm Lawrence Pavia. I'm the Senior Improvement Advisor that's leading on our residential rehab work, but obviously so much crossover into Matt. So for our group, I'll not go back over some of the things that have already been said. I think there was a bit of a feeling in our group that maybe we need some more information around what it is and thoughts around, does this need extra funding? So I see that Tracey's maybe put an answer to that question back in the chat so that people could have a wee look at. I think there was also thoughts around, well, who does this need to involve? Who are the people and services that we'll be looking to get experiential data from? And certainly within our Resi Rehab programme, we view involvement as people who use services, family carers, family members and carers, but crucially also people who are delivering those services, because their experiences of trying to deliver MAT standards will be just as useful as getting those experiences of people who are trying to access some of the services. We also spoke about the kind of thought process around quality assurance versus quality improvement. So, you know, the MAT standards benchmarking report is very much around quality assurance, but how do we take, and that's a big question for me as well, is that how do you take the learning and turn it into action? So you know, there's this concept of listening to people sometimes stops there, I think. And I think what we need to get better at, and certainly coming from the group, is thinking about, well, how would we take that action and turn it into learning? And I think for me personally, as a quality improvement person, it's about how do you do that quickly? Yeah. You know, we want to take action on learning quite quickly. So that certainly came through. But other than that, Ruth, there was a lot of similar thoughts from the rest of the group. Thank you.
Yeah, I think it's fair to say the reflections are shared in terms of the work that we've been doing around involvement within residential rehab, and so hopefully a lot of that can be kind of shared with colleagues within the MAT space if they're looking for models of how to do that engagement well. This feels like a seamless transition over to one of our involvement officers. Julie, are you there to give feedback in your group?
I am, thanks Ruth. And just as what you were saying there, what we were hearing really fits in what we're hearing within residential rehab programme as well. So hello, I'm Julie Davidson. I'm one of the involvement advisors on the Resi Rehab programme. We spoke about that family members at times still aren't feeling comfortable with telling their experience and being involved. And as Suze was talking about earlier, this could be because of past experiences, but this can be helped by services such as Scottish Families, the services working with third sector organisations to overcome that, to build the relationships and to build that trust. We also spoke about different rural and urban needs, so going back to what Adrian was saying as well, so people living in the more rural communities being identifiable, so maybe being more reluctant to take part in things, and also if people want to take part but want to go maybe out with their town to a different town, transport issue. That's the transport thing coming up again, and how we overcome that. We didn't really get a solution around that, because I think it's a whole national issue about transport. But people felt they were implementing things like online support and telephone, calls that still help people, in WhatsApp groups. So just looking what was used in COVID and how that works now. And that peer support and research model. So instead of people talking to the services directly, bringing that peer support model so that people can then build the relationships and build that trust with people who have been through similar experiences. But I think that was the main thing. Thank you, Julie.
Great, thank you so much. I'm thoughtful of time, so I'm just going to try and invite Niamh and Becky in. And Niamh, do you want to introduce yourself and go first, and then we'll pass to Becky?
Hi everyone, so I'm Niamh McIver. I'm the other involvement advisor for the Residential Rehab Pathways programme. I'll just try and go through this pretty quick. So we only really got to the first 2 points. There's a lot of discussion in our group. So the main kind of challenges that they saw were that consistent approach across services and that including areas and in different MAT standards. Around that standard of community engagement and how that'll look across, of being aware that there could be different variations and levels of community engagement, and how do we make that standardised, and how do we make sure it's of a certain level of quality in each area. And that kind of moves on to, you know, making sure that all the community engagement that happens is meaningful and it has a big impact. They also spoke about the culture and how there's a barrier around services maybe not wanting to hear the negatives and then not taking that engagement that they've done on board, and how can we combat that. Also around the different people that we engage with and how maybe we're still missing potential people that we really want to engage with just because they are in vulnerable situations or maybe not quite linked into the services that are being part of maybe an engagement piece that's happening, and maybe that there's a bit of there's a gap between the ambition and the capacity that's happening. So that we have a big ambition about including people with lived the living experience, but actually what's funded around that capacity might not match that ambition, and then there is where the gaps and the consistency might lie in terms of how we can make it work. So around, someone was said about the leadership and making sure there's someone able to lead on this work in all the different areas to have that consistency approach, sharing good practice and sharing information and examples of where it is working, and making sure that that trauma-informed approach is spread right across all the services and all the engagement pieces. And maybe seeing how that could combat the getting engaged with people that are harder to reach in those harder to reach communities. Thank you very much, Niamh. That was quite a lot, so thank you so much. Becky.
Thank you. I'll keep it really brief and I'll just give you an example of one thread of the conversation. There was lots of great conversation. So I think one of the challenges that people were concerned about is that there is a lot of information that's collected, a lot of experiences gathered, and then nothing happens. So I think they felt that was one of the challenges. So I think for question 2, how can we make this work? One of the things we talked about was utilising existing groups to carry out this work with. For question 3, we had, let me move on, just see what the question was. What's happening already? Well, what already exists is lived experience panels, living experience panels, family support groups. Those groups already exist. There's lots of them, staff forums, and how could you utilise them? And how could you utilise those existing groups and connect those people together in order to inform MAT Standard 11?
Thank you so much, Becky, for that. That is a massive amount of contribution, guys. Thank you so much for that, and so helpful for us in terms of how would we help colleagues and Tracey think about what are the key considerations in relation to MAT 11. So thank you so much for that. We are slightly over time, so I'll just be very brief in terms of next steps, but thank you to our facilitators and our speakers today. These events don't happen without your contributions. I'm really thoughtful about that, and thank you for taking your time to sort of spend with us on a Friday morning. I know it's a busy day of the week. So for everyone else, we'll be producing a bit of a summary of the event that we've had today, and we'll be picking up some of the kind of key themes. So your Miro boards will be used after the event. So please do go back to them if you think there's anything in particular that you would like to use them for or contribute. There's a poll on the screen if you wouldn't mind answering that. We're trying to take a bit of live feedback, because you know how it is with evaluations, you always leave it to the end and then you get limited kind of feedback. So please take the time before you log off today just to complete that poll. That would be great. But thank you so much. If there's anything you want to share with us, please do so in the email that I gave you in the chat earlier on today. You do find us on Twitter anyway, sharing events and things like that, and our team are available to be contacted if you've got any specific areas of interest that you'd like to use this webinar series for. So have a great afternoon. Thank you so much for your time today, and I'll probably see you for the next one in a few months. Thank you.